Good afternoon everyone. Today's topic for discussion is thyroid histology and applied anatomy. The thyroid is a bilobed butterfly-shaped endocrine gland with rich blood supply situated in the front and the sides of the neck in the lower part. It secretes thyroglin, which is the T4, triiodothyronine, which is the T3, and calcitonin. The thyroglin and the triiodothyronine regulate the basal metabolic rate and stimulate the somatic and the psychic growth, while the calcitonin plays an important role in the calcium metabolism. This is the only gland which is using natural iodine for the synthesis of the hormones. Now let's have a look at the hypothalamus pituitary thyroid axis. When there is decrease in the T3 and T4, it stimulates the hypothalamus to release thyroid releasing hormone, which in turn acts on the pituitary to secrete thyroid stimulating hormone, which further acts on the thyroid gland to increase the secretion of the T3 and the T4. The T3 and the T4, by the negative feedback mechanism, decrease the levels of the thyroid releasing hormone and the thyroid stimulating hormone. Now let's have a look at the structure of the thyroid gland. The gland consists of the right and the left lobes that are joined to each other by the isthmus. A third pyramidal lobe may project upwards from the isthmus. The lobes are conical in shape, having an apex, a base, three surfaces, lateral, medial and the posterolateral, and two borders, anterior and posterior. Let's have a look at the thyroid structure. This is the anterior border while this is the posterior border. This is the lateral or the superficial surface. This is the medial surface and this is the posterolateral surface of the thyroid. The two lobes are joined to each other by the isthmus. Each lobe of the thyroid measures about 5 by 2.5 by 2.5 cm while the isthmus measures 1.2 by 1.2 cm. The thyroid gland approximately weighs 25 grams. Situation and the extent. The thyroid gland extends from the C5 vertebra to C7 and T1 vertebra. It is situated on the upper part of the trachea with each lobe extending from the middle of the thyroid cartilage to the 4th and 5th tracheal ring, while the isthmus extends from the 2nd to the 4th tracheal ring. The thyroid has a true capsule, which is a peripheral condensation of the connective tissue of the gland. The venous plexus of the thyroid gland lies beneath the true capsule. The false capsule of the thyroid gland is derived from the pretracheal layer of the deep cervical fascia. It is thick on the inner surface of the gland where it forms the suspensory ligament of Barrett. It is firmly fixed to the laryngeal skeleton. Now let's have a look at the relations of the thyroid gland. Towards the anterior of the thyroid gland are the muscles sternothyroid, sternocleidomastoid, sternohyoid, and the omohyoid. Posteriorly situated are the two tubes, trachea and the esophagus. Towards the medial side of the thyroid gland are the two muscles, the inferior constrictor muscle and the cricothyroid muscles. Two nerves also lie medial to the thyroid gland, which is the superior laryngeal nerve and the internal laryngeal nerve. The blood supply of the thyroid gland is as follows. The arterial supply is mainly derived from the superior thyroid artery and the inferior thyroid artery, while the venous drainage is by the superior thyroid vein, middle thyroid vein, and the inferior thyroid vein. The superior thyroid artery is a branch of the external carotid artery. It branches at the upper pole of the thyroid gland into anterior and a posterior branch. As we can see, the external laryngeal nerve lies in close proximity to the superior thyroid artery. The inferior thyroid artery is a branch of the thyrocervical trunk. As we can see, it branches at the lower pole of the thyroid. The superior thyroid vein and the middle thyroid vein drain into the internal jugular vein, while the inferior thyroid vein drains into the thyrocervical trunk. The lymphatic drainage of the thyroid gland is to the upper deep cervical lymph nodes, lower deep cervical lymph nodes, pretracheal and paratracheal nodes. It is important to know the lymphatic drainage of the thyroid gland in order to know where the carcinomas are arising from the thyroid gland can metastasize. The thyroid gland develops from the medial endodermal thyroid diverticulum, which grows down in the front of the neck from the floor of the primitive pharynx. The lower end of the diverticulum enlarges to form the thyroid gland. The rest remains narrow to form the thyroglossal. The position of the upper end of the thyroglossal duct is marked by the foramen cecum of the tongue, while the lower end often persists as the peripheral lobe of the thyroid gland. The thyroid gland becomes functional during the third month of the development. The remnants of the thyroglossal duct may form thyroglossal cysts or thyroglossal fistula. The characteristic of the thyroglossal cyst is that it moves with deglutition and also with the protrusion of the tongue. Some thyroid tissue may also develop at the abnormal sites along the course of the duct, resulting in lingual or retrosternal thyroid. Let's have a look at the thyroglossal cyst. Thyroglossal cysts are one of the most common causes of midline neck masses and are generally located caudal to the hyoid bone. They can occur anywhere along the path of the thyroglossal duct, from the base of the tongue to the suprasternal notch. This is a microphotograph showing thyroglossal cyst lining by pseudostratified ciliated columnar epithelium. Histology of the thyroid. The functional unit of the thyroid are the thyroid follicles lined by the single layer of cuboidal to columnar epithelium bounded by the basement membrane. They contain a homogeneous colloid which is stained pink on the HNE preparation. The follicles are divided by fine collagenous septa which convey a rich blood supply together with the lymphatics and the nerves. These are the thyroid follicles showing homogeneous colloid and the lined by the cuboidal epithelium. The thyroid follicles store thyroglobulin, which is an iodinated glycoprotein, which is the storage form of the thyroxine and triiodothyronine. When inactive, the thyroid epithelial cells are flat to cuboidal, and when active, they are tall and columnar. Here we can see the inactive follicle lined by the cuboidal epithelium and the active follicle lined by the columnar epithelium. Thyroid epithelial cell functions are as follows. Synthesis of the glycoprotein component of the thyroglobulin, the conversion of iodide to iodine, iodine linking to the glycoprotein, and the release of the triiodothyronine and thyroxine into the adjacent capillaries. Now let's have a look at the thyroid C cell, which is also known as parafollicular C cells. They are found as individual scattered cells in the follicle lining or as small clumps in the interstices between the follicles. They secrete calcitonin, which is a physiological antagonist of the parathyroid hormone, which thus lowers the blood calcium level. These are the thyroid C cells interspersed in between the follicles. Now let's have a look at the applied anatomy of the thyroid gland, starting with goiter. Goiter refers to the abnormal enlargement of the thyroid gland. It can be caused by both hyperthyroidism or hypothyroidism, the most common cause being the iodine deficiency. The other causes are Hashimoto's thyroiditis, Graves' disease, multinodular goiters, and tumors. Goiter only signifies the enlargement of the thyroid gland, and it does not tell whether it is a hyperthyroid state or a hypothyroid state. The enlarged gland may displace or even compress the neighboring structures, leading to the pressure symptoms. If the growth is malignant, it tends to invade or erode the neighboring structures, accounting for the extrathyroidal extension. Now let's have a look at the causes of the hyperthyroidism and hypothyroidism, starting with the causes of the hyperthyroidism. are the diffuse hypoplasia seen in Graves' disease, hyperfunctioning multinodular goiter, hyperfunctioning adenoma, iodine-induced hyperthyroidism, neonatal thyrotoxicosis associated with maternal Graves' disease, and TSH-secreting pituitary adenoma. Well, the causes of the hypothyroidism are genetic defects, thyroid hormone resistance syndrome. It can be seen post-ablative, after surgery, after radioiodine therapy or external irradiation. It can be seen in autoimmune hypothyroidism, that is in Hashimoto's thyroiditis, and in iodine deficiency. Let's have a look at the classification of the thyroid neoplasms. The benign are the follicular adenoma and the Hürthle cell adenoma, while the malignant is the papillary carcinoma, which is the most common variant. Next is the follicular carcinoma, medullary carcinoma, Hürthle cell carcinoma, and anaplastic carcinoma. Cells of origin of the thyroid neoplasms. The follicular cell originated thyroid neoplasms are the papillary, follicular, Hürthle cell, and the anaplastic, while the parafollicular cell origin neoplasm is the medullary carcinoma. Let's have a look at the various types of the thyroidectomy. First, there is lobectomy, which includes the removal of the single lobe of the thyroid gland. Next is the hemithyroidectomy, in which a single lobe of the thyroid gland along with the isthmus is removed. Next is the subtotal thyroidectomy, in which whole of the thyroid gland is removed, leaving behind 4 to 5 grams of tissue. Next is the near-total thyroidectomy, in which whole of the gland is removed, leaving behind tissue in the vicinity of the recurrent laryngeal nerve. And last is the total thyroidectomy, in which whole of the gland is removed, leaving behind no tissue. The superior thyroid artery is ligated near the gland to save the external laryngeal nerve, as we have seen, because superior thyroid artery and the external laryngeal nerve run in close proximity. The stem of the inferior thyroid artery is not ligated during the thyroid surgeries so as to maintain the blood supply to the parathyroids. Let's briefly have a look at the thyroid function tests. In primary hypothyroidism, there is decrease in T4 and T3, which in turn increases the thyroid stimulating hormone. In subclinical hypothyroidism, the T3 and the T4 levels are normal, but the TSH levels are high. In hyperthyroidism, as the name suggests, there is increase in T3 and T4, which in turn reduces the thyroid stimulating hormone. In subclinical hyperthyroidism, the T3 and the T4 levels are normal, but the TSH levels are reduced. While in pituitary diseases, there is decrease in T3 and T4 with either normal to decreased levels of thyroid stimulating hormone. In T3 thyrotoxicosis, there is increase in T3 with normal levels of T4. Now let's also have a look at the parathyroid gland. Parathyroid glands are two pairs of small endocrine glands that lie in the posterior border of the thyroid gland within the false capsule. The shape of the parathyroid gland is oval to lentiform, with its dimensions being 6 by 4 by 2 mm approximately and weight being 50 mg approximately. The superior parathyroids develop from the endoderm of the fourth pharyngeal pouch, while the inferior parathyroid develop from the endoderm of the third pharyngeal pouch. The vascular supply of the parathyroid is mainly through the inferior thyroid artery. As we have seen already, during the thyroid surgery, the inferior thyroid artery is not ligated so as to maintain the blood supply to the parathyroid gland. It also derives its blood supply through the anastomosis between the superior and the inferior thyroid artery. The parathyroid gland secretes the parathyroid hormone, which is responsible for maintaining the blood calcium levels. In hypothyroidism, it leads to hypocalcemia, which causes tetany, in which there is involuntary muscle contraction, while the hyperparathyroidism leads to hypercalcemia, in which there is symptoms of bone pains, kidney stones, and the abdominal pain. The parathyroids are found embedded in the thyroid tissue proper. The thin fibrous capsule of the parathyroid gland gives rise to delicate septa which divide the parenchyma into the nodules of the secretory cells. The glandular cells of the parathyroid are mainly of two types. The chief cells or the principal cells are the cells which synthesize and secrete parathyroid hormone, and the other type of the cells is the oxiphyll cells whose function is still unknown. In parathyroid hyperplasia, the gland might increase in size and become hyperfunctioning, while in parathyroid adenoma, a single nodule becomes hyperfunctioning without increase in the size. These are my references. Thank you.